Okay, so I am one of the crazy Americans who helps with this class. So I am Joel Vaughan, and I've been introduced a couple different times. Just briefly about myself, I'm an internal medicine doctor as well as a pediatrics doctor. Practiced in America for not quite 10 years. And then the whole time I was practicing in America, I was teaching a course very similar to this for the American Medical School from which I graduated, and it was located near to my practice. And so I like this content. I think it's really important. If you look at what am I going to be doing as a doctor for most of my career, these types of skills, how do you get information from a patient, either by history taking or physical examination, are the things you will use every single day, every single patient you see. Right? You may not use biochemistry every single patient you see, but you will definitely use these skills with every single patient that you see. So I like teaching this class. Hopefully we can help you guys become excellent physicians by learning this material really well. So general examination part 2. So Dr. Omar has already covered the general examination part 1. And so what do we mean by that? General examination. You know, when a patient walks into a room, you notice a number of things immediately. You learn many things about a patient before you ever begin speaking to them, right? You'll notice what kinds of things when they come into your office.
The way they walk.
The way they walk, their gait.
The name.
Posture. What else?
Facial expressions.
Facial expressions, color, odor, all of these things, right? So we're going to continue that same process and define and refine. You'll notice lots of things. What we're training you to do is to describe specific things you are seeing to help you make a differential diagnosis and make decisions about this patient, right? So we have a very human skill. We can tell when someone in front of us is sick or ill or struggling in most cases. What we're teaching you all to do is to be able to describe it medically and to use it to make decisions that will help the patient, we hope. Okay? And why do we do this? Why do we care? I always start lectures that I give in this way to remind us that we are doctors, we are only human beings, we will make mistakes, but we're tasked with this huge responsibility of taking care of human beings. Why is that such a huge responsibility? Well, God made human beings. Therefore, they are very valuable. Therefore, we should take really good care of them. If you remember that every single time you see a patient, you will become a good doctor. Okay? It's not always about what you know, but having that heart, that motivation to love and care for people because they are valuable is crucial. And that's true no matter what. I'm not Muslim, most of you are, but we can definitely agree on those facts, correct? That human beings are extremely valuable, we should take really good care of them, we should be excellent at what we do to fulfill those responsibilities. So that's my little preamble every time I give a lecture, because this is the first time I've lectured to all of you. I felt it necessary to say it in depth. So let's go on to what we're actually going to talk about today. So what's the context of this? You guys, again, you've already had the first lecture on this topic, but this is the whole process in one diagram. And one of the great ways for you guys to use McLeod's is to use the diagrams and the tables and the charts. It can be difficult, I know, to read a lot of text in English, especially medical text. However, most of the important information can be found in diagrams, tables, things like this. So do pay special attention to these things. They will simplify your learning a lot as you use McLeod's. So we're just going through the whole process from meeting the person, through the history, making a differential diagnosis, sort of a working diagnosis, what do we think is going on as we head into physical examination. And we have this general process that is the overarching thing we do that Dr. Omar talked about last time, is this idea of inspection, palpation, percussion, auscultation. We look, we touch, we tap, and we listen. Okay? Each step along the way to various parts of the body. And then we confirm or refute our diagnosis at the end, right? It's a working diagnosis, and we're working towards an answer for the patient, and what are we going to do for them, okay? That's the whole process. So, this is a portion of the process. So again, another example of a table that's in McLeod's that I think is helpful. how do you do this? So you don't have to do it the way I say or the way McLeod's says to do it. But you do have to have a system. Why? Because it is dangerous to leave things out, to forget to do things, to forget to look for pieces of information. So having a system prevents you from making what we call errors of omission. In other words, it's an error because I didn't do something I should have done. Okay? So we want to start with that handshake and introduction. That's part of the examination, right? Because we're feeling they have sweaty palms, like Dr. Omar talked about. We're noticing their general appearance while we're talking to them. We're doing physical examination even while we're speaking with them. We're noticing their speech, their quality of sound production, their ability to find words, the ability to articulate words, these kinds of things. Noticing also their coloring, their body habitus. Are they obese? Are they really thin and malnourished? Difficulty breathing. All of these things we're going to notice. And going on now. I cut it off at hands and radial pulse. That's kind of where we got to last time. But there's a whole table with the whole examination process in McLeod's. It's good to look at. So focusing in on other general issues. You guys mentioned a number of them that we talked about last time. We're just going to continue through the rest of them that we want you to think about. And one really major one, which you will notice right away, is the patient's level of consciousness. What do we mean? We mean, are they awake or not? Okay? And that will be very obvious to you early on. So how do we assess this? How do we categorize this? Well, in general... Oh man, my slide's missing. Really? So I'm missing one slide, I think. Give me a second. No, there it is. It's in the wrong order. So, in general, you can think about it in this way. If they are normal, then they are alert. You're having a normal interaction with them. They're not sleepy, they're not clouded, they're not having difficulty staying awake, they're alert. Lethargic, they're kind of having some difficulty staying awake. They're just slowed down. And these are clinical terms. I don't care if you remember these terms, but I'm just leading you through different levels of consciousness we can think about. Obtunded means they're awake, but they're not really in reality. Okay? They may touch on reality at certain points, but they're not really fully there with you, even though their eyes are open. Stuporous, their eyes are open, but they are not with you in reality at all. And then comatose, they are in a coma. They are not at all interactive. They are not conscious at all. Okay? So declining level of consciousness as we go through. Fortunately, most of the patients you see will be alert. And you can talk to them. But you do have to sometimes deal with patients who are not. And you have to go through this process of evaluating their consciousness. It's a key clue in finding out what's wrong with them, right? So one way we do that, in serious cases particularly, but this is just a way of quantifying, of putting a number to, or putting a level on, or measuring consciousness. Okay, it's not suitable for every scenario. So this is really just an example of how to think about consciousness, specifically in a patient who suffered central nervous system trauma, head trauma, or something like that. So you use different aspects of the patient's response to quantify how conscious are they. So you look at their eye opening. Okay? If it's spontaneous, that means they're normal. They're doing what you or I would do. We open our eyes whenever we want to. We close them when we want to. However, if they're closed, but they'll open them to speech, okay, that's 1 point less, but they're still pretty alert and awake, on down to they only respond, they only open their eyes when they're hurting, so you might apply a painful stimulus to get them to open their eyes, or they just don't respond. 1 point. You'll notice that if somebody has no response with their eyes, and no response with speaking, and no response with moving, they get a 3. So even somebody who's basically dead neurologically gets 3 points. Okay? So as you descend down, their odds of survival go down. Okay? You get below 10, you're looking at massively decreased survival from whatever their injury was, whatever their problem is, giving them this decreased consciousness. So if they're 15, they're perfect, they're normal. If you add all these up, so you give them a point, give them their points for eye opening, their points for their speaking, their points for motor response, you add them up. If it's 15, they're completely normal. Less than 8 is comatose, and totally unresponsive, like I said, is 3. Why don't they get 0? I don't know. To me, they should get 0. A couple things on there. When they withdraw from pain, I can't walk away from the mic, sorry. Flexion, that's when you apply pain and they do this kind of thing. Okay? Versus extension, that's much more serious. It shows that they have complete loss of their upper cortex, their forebrain, basically. It's totally involuntary, this response to pain. Okay, so it's a lesser response. But that's when we say flexion response, it's when they kind of curl up in a ball, versus extensor or decorticate. In other words, there's no cortex involved posturing, where they just completely stretch out. Okay? That may not be obvious from reading clouds, so I would cover that. And we've already done that one. Excellent. So, another huge... So, consciousness, very important, right? Very important. Okay? Have to make note of that. If it's normal, it's normal. Great. Most will be, but not always. Hydration status. Another crucially, vitally important aspect of your patient. Why is that? What do we mean? So, hydro, whenever you see that root word, or root as part of a word, we're talking about water, right? So in this case, we're referring to water. We're talking about hydration. Why is it so important? Why is water balance and water content so important to us as doctors and to our patients? Because we're mostly water, right? If you had to pick one substance that makes up most of us, it is water. 60 to 65%, though of course it does vary. Men have a little bit more than women. It does vary by age, babies versus the elderly. But in general, about 2/3 of us is water. Okay? Well, that's nice. Why does that matter? Well, it's crucial for maintaining our metabolism. So the metabolism is like the engine that runs our body, right? It processes our food and brings us fuel in the form of, ATP and these sorts of things. So you have to have a cc or a milliliter of water for every kilocalorie you want to metabolize. So you have to have water or you will die. That's why none of us can survive for more than a day or two, a few days, without water. We can live for a long time without food, but water not. We have to have water. It's crucial for maintaining our circulation. How do we deliver this fuel to our tissues? We circulate it in our blood, which of course is mostly water. So you get circulatory collapse without adequate water reserves. Okay? And then so on. That's not the only significance of water, but this is some of the main stuff. And let me say this too. In hospitals here and in hospitals in America, we often lose track of hydration status, and we will be unintentionally underhydrating people or overhydrating people, and we're causing them harm. So you want to assess hydration status on every patient, every time you see them. Okay? You have to do it. Don't neglect it ever. So, we can talk about different forms of problems with water. So you may be dehydrated. So that means literally without water, hydro, right? So we are without water in that case, or we don't have enough. This is actually pretty difficult to assess. It can be hard to know how much water someone has lost. We'll talk about how do you know it in a second, okay? But don't think this is simple. If you find obvious signs of dehydration, that's bad because it means they are very, very dehydrated, not just a little bit. Okay? Overhydration. There's too much water on board. Well, this implies what? That more water is coming in than you can get rid of. Okay? Versus dehydration, more water is going out than we can take in. These signs and symptoms tend to be more evident than those of dehydration. But again, not necessarily. But it does tend to be a more obvious situation when you are clinically or significantly overhydrated. So dehydration, how do you assess it? You guys are early on, and so you may not have heard any of these things before, but we look at a number of things. And I listed them in sort of the order of importance for me, in terms of the things I look at to accurately assess hydration. But in some ways, if you read books and articles, they kind of start with the bottom one and then work their way up. So let's talk about this. So skin and soft tissues, it can be very obvious if they have eyes that are sunken in because the tissues have lost their water. If their skin tense up like it does in that picture. So you pinch some skin, usually on the chest, in this case it's on an extremity, And when you let go, it stays up. We call that tinting of the skin. Yeah.
Yes, we do it when we want to know if anyone is fasting or not. So we are doing like this.
Yeah.
So that's how they will know it.
So we think of that, right? But this is a sign of very significant, very profound dehydration at this point. It's one of the last things you will see in a dehydrated patient. All of these other things will happen before they get that last one. In fact, you will rarely see that. You will rarely see tinting of the skin. You guys all like my But I think it's better for you guys probably if I really help you work on the English side of things. Just tell me if I gotta slow down and define things better. But yeah, so skin and soft tissue changes are late. It's bad when they get to that point. We want to find it before then. Okay? So what do we look at? Well, weight is the most obvious place to look. We know, or you will know if you don't know already after you have this lecture, that 1 liter of water weighs a kilo. So, if their weight is 3 kilos down in the last 5 days, they've lost 3 liters of water probably. It's unusual to have significant weight loss from fat tissue and that sort of stuff over days, right? But water will do that. So weight, if you know their normal weight, and that can be the issue, right? You don't always know it. But if you know it, this is the most reliable way to judge their fluid losses. The number of kilos they've lost in the last couple of days is the amount of water they've lost in liters. Pulse rate and quality. So we talked about how do you assess pulses already, but the rate will obviously be high because you have less water, so you're having to pump more times because you have a smaller volume of going forward from the heart. Okay, I'll try to stay away from stroke volume, cardiac output, and all of this sort of stuff. But if you want blood moving forward out of your heart and you're losing water, you're having to pump more frequently to move the same volume of blood, right? So your heart rate goes up. And then afterwards, it can also be this problem of not only that, but the amplitude, in other words, the rise, the strength of those pulsations, they'll be more rapid, and the strength will be less. And all the things you can do. I mean, I'm not going to go into detail on pulse again, but you'll see it in the pulse pretty early. Okay? So heart rate above 100 can be caused by that. And then you move even further to these other objective measures of water loss. And these, I like these because they're all very measurable. They're not perfect, but you can objectively measure each one of these things. Blood pressure. It could be just low, much lower than normal for the patient. That does go along with dehydration, right? Or specifically, if you have them go from laying down to sitting up, or from sitting up to standing up, because of gravity and the heart having to work against gravity, the blood pressure will fall if there's not enough water involved. Okay? Specifically, it falls by more than 15, that's mmHg is millimeters of mercury. This is the pressure measurement we use for blood pressure, right? So it will fall, the systolic number, the top number, will fall by more than 15 if they have orthostatic, positional, postural, all these words we use. It just refers to their position, either laying down or sitting up, laying down or upright. That pressure will fall. They will have postural changes in their blood pressure. Okay? So I like them to all measure, but notice there's no one perfect test to assess hydration. So that's important to make note of and recognize, right? And then again, we get to the end of things. When you're seeing these soft tissue changes, these people need pretty immediate medical care. They are in pretty difficult circumstances by that point. Okay? They need immediate, we say, resuscitation. In other words, resuscitation is we're giving life back to someone. So we think of it when we do compressions or we shock them like you guys have probably seen on House or something like that. But fluid resuscitation is much more elemental, basic, and necessary. In other words, you do it much more frequently than any of those other things, but it's really key. They are about to die at this point, not literally, I mean the mortality statistics are not significantly high, but they have significant severe medical problems and you have to address those immediately. The other problems you do as well, but it's not as dire, it's not as severe typically, okay? As if you have all of these things. talk about overhydration. It's an English term. But we might talk about volume depletion with dehydration. There's a volume of blood in my body. We might talk about being fluid overloaded. You'll hear people say, at least in America. Just the idea there's too much fluid on board. And most of the fluid we're going to have is water. Okay? So, we can still look at weight. Okay? We can still look at their weight. If their weight has gone up by 5 kilograms over 5 days, we assume that most of that is water, and we probably need to take away about 5 liters from them by medication or dialysis or whatever the need is, okay? So it's one of the things, if you admit someone to the hospital with heart failure, in other words, their heart is unable to pump blood from the central circulation, the heart, down to the kidneys, the heart is just too weak to make that pumping effort, then they will have fluid overload, right? They will be holding on to more fluid than they should. In other words, they're taking fluid in but not getting rid of enough. In that situation, we measure weight in the hospital every day to see how much progress we're making. Okay, if they came in at 100 kilos and now they're down to 93, we're feeling pretty good about things. And then sometimes you go too far and you tip them into dehydrated. And you notice, oh, their blood pressure is starting to fall. Maybe we should back off on the medicine we're giving them to take away fluid. That kind of thing. Other reasons you can become overhydrated, obviously the heart is a major one. The kidneys, if the kidneys are unable to excrete fluid, one of the big things the kidneys do is get rid of excess fluid. They get rid of water and other things. But for purposes of this right here, they get rid of water, and if they are not functioning, you will become volume overloaded, overhydrated. It's one of the reasons we do dialysis on people. We take water away with a machine in those people because their kidneys are unable to do it, either at that time or ever after, if they've had total failure. So, other things we look for edema. And that is not the spelling in McLeod's because I'm an American and I was typing and not thinking about what McLeod says, but it'll be O-E-D-E-M-A in McLeod's, but same word, just spelled differently. Americans do everything wrong. So with edema, what we're talking about is fluid in the soft tissue space, okay? So the fluid should be mostly in cells and in blood vessels. But if it begins to leak out into the soft tissue space, we get swelling of the skin and soft tissues. So you can see this picture of someone's feet and ankles here. They may not look very swollen. One of the things we do is we will press in with our thumb, usually over the anterior tibia, in the shin we call it. And then we release our thumb. If they are edematous from heart failure or kidney failure, typically a divot or a pit or a hole, however you want to say it, we just say a pit will remain. So they have pitting edema. Okay? And that goes along with fluid overload, fluid excess, overhydration. Okay? Too much fluid. So we think of that happening in the feet and the ankles. Okay, you guys may have elderly relatives who get swelling in their feet, that kind of thing. But in truth, it goes to wherever gravity is pulling it. Okay? So what about a hospitalized patient who hasn't been out of their bed in about 3 days? Where will that fluid go? So their legs are going to look pretty good. I'm thinking, wow, they don't have edema anymore. But where should I be looking? Their back. Yes, absolutely. You're going to look in that the lower back, the sacral area, because typically their head is a little elevated and their feet are slightly elevated, so gravity will tend to pull that fluid into the lower back, the sacral area. And so you look for that pitting in a different spot than you would look in a normal patient who, yeah, they're just getting up, they're walking around, they're upright a lot of their day, right? It's why people's swelling is usually much better in the morning, because they've been laying down all night, in their feet and legs, and worse as the day goes on, as they're upright longer. Okay? Actually, it can help the heart in heart failure. If you lay down, it's less effort and work to distribute that blood against gravity. Easier to deliver it back to the heart and that sort of thing. And so edema does get better with better delivery to the kidneys with laying flat, but it also just pulls it to different areas. So be aware of that. Just because it's not in their feet and ankles doesn't mean that they don't have fluid overload. Always check the lower back in a hospitalized patient. So the last one, I don't want to get too detailed. This is a first semester, first year class, but we'll mention it. So another place you can look is the jugular venous pressure. So by that we're referring to the jugular veins in the neck. There's an external and an internal, okay? Normally you will not see a column of fluid in that vein. It's collapsed down, okay? But if you become volume overloaded, you will begin to have fluid back up from the heart, from the right atrium, into the superior vena cava, into the jugular veins. Okay? And so you can actually measure the height of that and get an idea for what pressure of fluid is being put upon the heart. Okay? We're not going to talk in the cardiology section or the heart examination section. We'll talk about how you measure it. Don't worry about that now. But just know that it's a place you can look for signs of volume overload. That's the only importance of bringing it up right now. Alright, lumps and bumps and swelling. Okay? You might notice when somebody sits down in front of you that they have a massive bump on their head, or on their arm, or on their shoulder. Sometimes the patient will come to you for a different problem, and as you examine them, you will notice, there's a mass here, a bump, a lump. And you may ask them, have you noticed this before? They may say, no, I've not noticed it before. So it's really important to be able to characterize these things. Why? Because what are some possibilities? What could be causing that lump or that bump or that swelling? Say it loud. It's a big room. So yeah, trauma, right? It could be blood, a hematoma, a collection of blood under the skin. Absolutely. What else? Infection, I think I heard. Absolutely. You could get pus, white blood cells being deposited under the skin and causing swelling into a space. Yes?
Bacteria.
So bacterial, so infection. Somebody said edema. So we did talk about swelling, right? So obviously it could just be edema. I didn't mention this, and I should have. Not all edema is whole body. Sometimes it's just local. And usually that's not from a fluid problem. It's usually from an inflammatory problem or an allergic problem, right? Also, even generalized swelling isn't all from fluid excess. You can have leaky blood vessels for a different reason. You can have poor nutrition and poor protein. We're just trying to keep it simple, so I'm not going to get into all of those things. But know that not every time someone's edematous are they volume overloaded. Okay. So it could be cancer, right? If they have a lump or a mass and they haven't noticed it. It's why we will teach breast examination to our female patients to screen for breast cancer. We can argue later if that's a good screen or not, but nonetheless, it is something we do for people. So yeah, you want to be able to characterize things because we want to know, do I and does the patient need to worry about this or not? Right? Because usually if they come to you because of the mass, they're worried. And why are they worried? Because they're thinking cancer, severe infection, things like this. Okay? So this is my favorite mnemonic in medicine. We have lots of mnemonics in medicine. What is a mnemonic? It's where we have a word, and each letter of that word stands for a concept. And we use that word to help us remember the concepts, right? So this one is called space spit. Anyway, we won't go for that. It's easy to remember, space spit. It's just not a very common thing to come across. So this is what we're going to describe with lumps that we examine, and this is what's going to help us categorize this as a threat to the patient or not. Is it serious or not? S is size. How big is it? Right? Generally, the bigger it is, the more worrisome it is. But that's not true for every condition. And again, we don't need to get into all these criteria. But I do want you guys to get an idea of this is how we describe a mass that we're examining. Okay, so I do want you to know, just like we want you to know the Socrates for pain, or Socrates, site, onset, context. I want you to know this for lumps and masses. Because this will enable you to describe to yourself as you document, or to a colleague, what's going on with the patient. It will help organize your thinking. So size, position, where is it on the body? Okay? Attachments. So if it's attached to other things, that's typically more worrisome than if it's free moving. Okay? Consistency. Hard, rocky, firm is typically more worrisome, depending on the condition, than if it's soft and boggy. Although again, some serious things, like an infection, can be soft and we say fluctuant. In other words, you can push in on it pretty easily. So you can say it's hard, you can call it rubbery, like a rubber ball. Those are less concerning typically. It could be fluctuant, or you're able to move it around like fluid with your fingers, and that's, again, more consistent with infection or abscess probably in most cases, or a cyst. Okay? The edge, in other words, how well defined are the edges, that kind of thing. If it has poorly defined borders, that means it's probably attached to other tissues and it's probably something bad, versus if it's what we say, well circumscribed, and all we mean by that is it's separated from the tissues that are around it. Surface and shape, and is it smooth, is it rough? Does it have a regular shape like a circle or an oval, or an irregular shape like an amoeba? Again, that's more concerning, right? Stretching out in other tissues. Pulsations, thrills, and bruits will help you know if it's a vascular lesion or not. If you have a lesion on the arm that's bump, 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 it's probably from a blood vessel. And anytime you have big swollen blood vessels, they're at risk from rupturing. That can be bad. And so I've had definitely patients sit in front of me and almost die from bleeding to death because of rupturing something like this. Then we look for signs of inflammation. Again, you probably haven't gotten to these yet in your studies, but you will. There are certain cardinal signs. There's main signs of inflammation. Some of them are, is it red? Does it hurt? Is it tender when we touch it? And is it warm or hot compared to the tissues around it? Those all go along with inflammation. A major cause of inflammation is infection, but there are other reasons you could be inflamed as well. And then transillumination, we try to shine a light across it to see if it's solid or not, right? Light passes more easily through fluid than through solids, and so we use shining a light across it to see, is this a cyst, which typically is a benign type of lesion, not always, or is it a solid, what we call a mass or a tumor? And those can be more worrisome depending on these other factors. So, space spit. I'll try not to spit as I say it. So how do you do this? Really just what I just described. So this is one of those tables in McLeod's that describes to you the process of collecting that data. And I don't have to go through that again to describe to you the features. But again, you want to be able to identify its size, its position, its attachments, its consistency, these kind of things. I saw somebody raise their hand, but I want to finish my sentence. If you guys have questions, please feel free to ask either now or at the end. But anytime. It's okay to interrupt me. I don't mind. Okay, moving on. If you do have a question, please ask. So anyway, this is a great table in McLeod's to tell you, well, how do I go about assessing the space and spit criteria? This is how you do it. Okay, it tells you how to use your fingers to massage things to see if its consistency is hard or soft or rubbery, that kind of thing. It's pretty common sense, but it does give you some specific techniques you can use. And then we want to talk about lymph nodes. So I promise we're coming down the home stretch. I know it's difficult having an afternoon lecture, sometimes to stay engaged, to pay attention. Maybe the novelty of having a Westerner up front helps some, probably not very much because he's speaking a strange language. We have to concentrate really hard. But lymph nodes, so how I would think about this is lymph nodes are a specific application of the space spit mnemonic for masses. Lymph nodes are supposed to be there. However, often when we're examining them or making note of them, they are abnormal in size or consistency or signs of inflammation. Okay? So I put it last after lumps and swellings because you can use the same technique you use for any mass in assessing lymph nodes for the most part. Now, let's talk a little bit about lymph nodes. One, they're located throughout your body. And I started to put a diagram up there, and I thought, you know, then they're going to be overwhelmed by the number of lymph nodes there are in the body. What do lymph nodes do? Typically, their role is to filter out things floating around in your body that shouldn't be there. So, it is a place where certain white blood cells live. They're going to kill bacteria and viruses when they come through. So you'll filter those out. It's one of the reasons they get enlarged with infection, because they're growing in terms of the amount of stuff they're holding on to, because they're filtering out your blood and your tissues. Okay? Typically, fluid flows from the extremities towards the heart in these lymphatic vessels, and along the way there are lymph nodes like filtering stations. Okay? They're external, so you do have them above your clavicles, your collarbones, in your neck, front and back, on your scalp, in front of your ear, behind your ear. You also have them, of course, in the chest cavity, in the abdominal cavity, in the pelvic cavity. These kind of things. So they're everywhere. Again, I don't really want you at this point memorizing the location of every single lymph node in the body. I don't think that's appropriate to the level of what we're teaching. Nonetheless, they are everywhere, and so we'll give a couple of examples, because I do want you to have an idea of commonly assessed lymph nodes. Well, let's not get crazy. And that looks pretty crazy, doesn't it? Pretty long. Again, I only put it up there not to read it to you guys, and not to overwhelm you, but just to say, as bad as that looks, it encapsulates probably 5 pages of text. Okay? So it's just a good place to look for the technique of how do I examine the lymph nodes. So, I mean, you'll notice, you're looking at just these general principles. Most often when you come across lymph nodes, they're visible, right? That's the problem. Lymph nodes generally aren't visible. So if they are, you want to make note of that. Normally they're small enough, much less than a centimeter, so really small, that you wouldn't notice them unless you're really deep palpating for them most of the time. So if they're visible, you want to make note of that, because that's not normal, not typical. You're going to palpate each single one of them. And then you always want to be comparing side to side. In general, in human bodies, the way God made us, symmetry is good. Okay? In general. Okay? If you have something on one side, it's good to have it on the other. Okay? Lymph nodes are like that. You can tell sometimes that a lymph node is enlarged, not because it feels so huge, but because if you compare it to the same location on the other side, it's much larger than the one on the other side. Okay? So always compare side to side as you assess any mass, but particularly a lymph node where you know they will be found on both sides, bilaterally, as we say. Not lateral, one side, or unilateral, one side, but bilateral, both sides. Okay? And then you're going to go, again, use these space-spit concepts, because they're talking about what? The size. They're talking about location. They're talking about, and again, you're going to put a measurement on these things, so when you find one, if you can't tell with your fingers, okay, I have that's about 3 centimeters. No, you're going to want to measure, either with calipers or a ruler even, the size of these things, so you can describe it accurately in your note. So it's one of those things as a doctor, you really should have an accurate way on hand, a ruler in your pocket, a small tape measure in your pocket, because you have to measure things a lot. So you should definitely measure these things. No question. So then they go through specifics. They got the general principles, and again, it's consistency. It's looking for redness or signs of inflammation. Why? Because lymph nodes do become infected. They become red, warm, and tender. Okay? Lymphadenopathy or lymphadenitis in that sense. In that case, they can be cancerous. They're enlarged, but they're not red, and they're not tender, and they are attached to the underlying tissues. So we talk about these regions when we look at lymph nodes because they drain certain areas of the body. So if a lymph node is swollen, I need to be looking for problems. So if it's swollen in my anterior neck, I need to be looking for problems in the mouth and the throat. Okay? If it's behind my head, I'm thinking more of problems with the scalp. Is there a fungal infection of the scalp? That kind of thing. So you look for areas where there's hair loss and inflammation of the skin. These kinds of things. So you're looking at what region does it drain, where's the problem coming from. Sometimes the lymph node itself is the problem, but usually, most often, something that the lymph node drains is going to be the problem. Okay? So we break them down into regions. So cervical just means neck. Okay? So cervical lymph nodes. And there are a bunch of them. There are epitrochlear nodes. These are around the elbow. Okay? Important to know about those. There are inguinal nodes. So in that case, we're talking about the groin area, the top of the leg, below the abdomen. There are lymph nodes that are, the leg. If the leg becomes infected or inflamed, those lymph nodes will become enlarged. Okay? And again, as much as we're talking about the external lymph nodes, there are just as many, probably more internal lymph nodes, but we typically aren't aware of those because we aren't able to examine them as easily, right? But don't forget about them. You'll see them on CT scans. Or if you see a problem, say, in the testicles of a male, those lymph nodes are internal. The lymph nodes that drain that region are located close to the aorta. So you won't see swelling of the groin in most cases. Now, if it's the skin, that's different. So it's confusing and complicated. I don't want to confuse you or to complicate things, but just to give you some specific examples, there are lymph nodes in every region of the body. They're internal, they're external. These are some regions to be aware of and to be generally familiar with how you assess them. But again, those space-spit categories apply. You can use lump assessment on the lymph nodes. So just an example of how do you do it when it comes to the cervical nodes up top. Okay? You're behind the patient and you're kind of wrapping your fingers around their neck, not to choke them, but just to get in this groove behind this muscle we call the sternocleidomastoid muscle. It attaches down near the sternum, right? One head there, one head on the clavicle, so sternocleido. And then the sternocleidomastoid, so it goes up to the jaw, right? And in front of that muscle and behind that muscle are a number of lymph nodes. Okay? You may be able to feel them on yourself or not. It depends on what's going on. But you want to feel those for sure. Then you want to come to the base of the neck. There are lymph nodes in that area at the base. Lymph nodes, especially in this triangle that's formed with the neck and the collarbone and the trapezius muscle. Again, I know all these terms may be strange to you guys still, but just again, these are areas where you want to feel for lymph nodes. Then of course you feel for those posterior nodes before you're done. So they're anterior, they're at the base of the neck, and they're also posterior when it comes to the neck. Again, I tend to start with the scalp, but again, we can't show every single examination at a time. I'm going to wrap it up pretty soon. In case you guys have questions. You can look at the axillary lymph nodes. That's got a strong enough beam. So that's that bottom left is the axillary or armpit lymph nodes. And in that case, you want them to relax the arm at their side. If they tighten those muscles, it can be harder to do that. But you usually have them relax their arm and you stick your hand up between their arm and their chest wall as far as you can go up into the pit of their arm, the axilla, to feel if there's a lump or a bump up there. Okay? Say breast cancer. If you have that, drains to those nodes. So you want to be aware of those nodes being inflamed. There can be problems with the skin in that area. They can commonly become inflamed or infected, and so they can get enlarged in that scenario. This is the epitrochlear nodes in the bottom middle. So you're looking for lymph nodes around the elbow. You don't see it too often, but if there were inflammation or infection in the hands or lower arm, you would find them there. Or if you have generalized lymphadenopathy. Some people have lymph nodes swollen everywhere. The classic example would be somebody who has HIV, human immunodeficiency virus. Often when they're first diagnosed, they have diffuse lymphadenopathy, swollen lymph nodes everywhere. One space to look is the epitrochlear region. And then you have the groin area, the inguinal area. Okay? So there's a ligament there called the inguinal ligament. You're looking just below that ligament, and then medially, in other words, close to the middle. Okay? You have in your femoral area, your leg, upper leg, you have a nerve, a big nerve, the femoral nerve. You have the femoral artery. Then you have the femoral vein. Then you have this empty canal where you can have other problems that occur that I just lectured on last week for the 3rd years. And then you have the lymphatics, the lymph nodes. Okay? So they're more close to the middle, but they're still at the top of the leg. And again, anything in the lower leg that gives you inflammation or swelling can give you problems there. Question? Or just stretching? Just stretching. It's a dangerous thing to raise your hands in a lecture. No, it's okay. Alright, so this is just some of the sites you can look. And again, you're just applying these techniques to those specific sites. Each site has a slightly different technique, but largely you're using your fingers to assess size, Position, you're going to know size and position, usually somewhat size, more so with touching. And then of course the attachment, does it move around or not? Consistency, is it firm and rubbery? Most lymph nodes will be firm and rubbery. If they're boggy, you can push in on them a little bit. You think of infection like pus in there. And on down the list. So just use those same criteria. Learn the space spit really well and then apply it to the lymph nodes in these different regions as you go through the examination. So, in summary, it's always a happy thing when you get near the end of a lecture, right? The science says you guys only will remember the things I said in the first 15 minutes anyway, so it doesn't even matter what I say from here on out, right? But no, to help bring us back to what happened way back there at the beginning of the lecture, 1, when you see the patient, you will have an impression. They will strike you in some way, either as normal or abnormal. And if abnormal, then abnormal in certain ways. We want you guys to be able to describe in what way these things are abnormal. Okay? You want to better define your impression, that first impression, when they walk in the door, by specifically observing and describing aspects of what you see. So you can have a general impression, but you're going to break that down into their gait, their posture, their color, their smell, their speech, facial expressions, etc., 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 right? We want you to describe all those things. That will help you form an idea of what is happening right now with this person. And why do I care? I care because they're a human being made by God. I need to help them decide what's going wrong. That's why they came to you. And so as you have all of these ideas at first, as you observe more things, there are fewer and fewer possibilities about what could be going on, and we get to an answer we can work with. From today, I want you to make note of their level of consciousness and have some way of assessing that, from normal all the way down to comatose. And if there's a need to quantify that, you can use the Glasgow Coma Scale. Okay? It's not validated for all scenarios, and we misuse it a lot, but it's still useful, especially in the trauma setting. And it gives you a general idea of people's level of consciousness. You want to be able to assess hydration status, and as I said, it's not super easy, so I would really focus on that Glasgow Coma Scale for consciousness and hydration status. These are global things that are hugely important. Okay? We want to know how to assess a lump. Sometimes the patient comes to you with a lump. Sometimes you discover one while you're talking to the patient, examining the patient. Okay? And as a subset of lumps, at least in my brain, and Clouds doesn't really say this, think about lymph nodes. What they do, what they're there for, the problems they can have, and then how do I examine them? Well, largely I examine them like these lumps and masses we were talking about before that. Okay? And then of course, always, always, always remember, most of the general examination is inspection, right? We're just watching the patient, most of it. But we are talking some about palpation. We've looked at it, and now we're feeling it. We haven't percussed much today. We say a drum player is a percussionist. They're beating on things. We haven't tapped a whole lot on things just yet. But we will with certain systems of the body. The point is not that you do all 4 of these things every single time, but that you have to think about all 4 of them every single time and choose the ones that are appropriate. But don't leave it out. You will actually auscultate or listen to, say, one of the P letters in space spit is whether it has a pulse, a pulsation, or a thrill. That's something a thrill you can only hear with your stethoscope put on, unless it's really, really loud. So that's a listening thing, a thrill we mentioned today. So always remember that sequence: inspection, palpation, percussion, auscultation. And it's all about taking a lot of data and funneling it down to something that's measurable and describable in categories in my brain so that I can get a working idea of what's wrong with the patient so that we together, the patient and I, can formulate a plan of attack, a plan of how to make them better, right? So that's all we're doing. These are the reminders at the end to help you get there.